You think the flare is over. Your labs say so. Your doctor says so. You're functioning again. But something still feels off. And you can't explain it without sounding like someone who just refuses to get better. Here's the truth. The flare may not actually be over. It may have just stopped being loud. And quiet is not the same as gone. Let's go back to the beginning. Not the beginning of your diagnosis, the beginning of what a flare actually is. Because most people have a simplified version of it in their heads, and that simplified version is part of the reason they get caught off guard. A flare, in most people's understanding, is when things get bad. Symptoms spike. Dryness intensifies. Fatigue becomes crushing. Joints ache. Brain stops cooperating. And then, eventually, it gets better. The flare ends. You return to your baseline. That's the model most people carry. But here is what that model leaves out. Sjögren's syndrome is not an infection. It does not behave like a cold or a bout of pneumonia, where the pathogen is either present or it isn't. Sjögren's is an autoimmune disease, which means the source of the problem is your own immune system, and your immune system does not have an off switch. It does not stop when symptoms quiet down. It does not go dormant because you had a good week. What happens during a flare is that the immune system's attack on your moisture-producing glands, and increasingly, your nervous system, intensifies. Lymphocytes infiltrate glandular tissue. Inflammatory cytokines flood the bloodstream. The body becomes a war zone that you can feel from the inside. And then, sometimes, the intensity drops. The cytokine storm settles. The loudest symptoms pull back. And it looks, from the outside, and sometimes from the inside too, like the flare has ended. But the immune activity hasn't necessarily stopped. What's happened is that it has shifted from acute to chronic. From loud to quiet. From visible to subclinical. And subclinical does not mean inactive. It means below the surface. Still there. Still doing damage. Just not announcing itself anymore. This is not a rare occurrence. This is one of the most common patterns in Sjögren's, and it is almost never explained to patients at the time of their diagnosis. So they spend months, sometimes years, cycling through what they believe are flares and remissions, when what they're actually experiencing is one long, shape-shifting disease process with variation in intensity. That changes everything about how you manage this. And it starts with recognizing the signs. And if that sentence just landed for you, if something in what I've described so far sounds familiar, I've put together a symptom map that shows exactly how this condition progresses, what shows up at each stage, and where the standard tests are most likely to miss it. Type symptom map in the comments right now and I'll send it to you directly. Because what I'm about to show you next is why that map matters more than most people realize, and why the stage you're in changes everything about what happens next. Let's talk about the moment the confusion sets in. Because it's almost always the same moment, regardless of how long someone has had Sjögren's. You've been through the acute phase. The bad stretch. And now you're in what feels like recovery. You're not back to normal, whatever normal used to mean, but you're better than you were. You're managing. And the people around you, who watched you struggle, are relieved. They tell you that you seem better. And there's pressure in that, gentle pressure, well-meaning pressure, to agree. So you agree. And you try to live inside that agreement. But your body keeps interrupting. Not dramatically. Not with a new crisis. Just with a low, persistent signal that something is still not right. A tiredness that sleep doesn't fix. A brain that won't reach full speed. A sensitivity, to light, to sound, to stress, that wasn't there before the flare, or wasn't this pronounced. A feeling of being slightly outside yourself. Present, but not quite anchored. You push through it. You tell yourself it's the aftermath. Recovery takes time. You've read that. You believe that. But weeks pass. And then more weeks. And the signal doesn't go away. It just becomes the background of your days. And at some point, maybe in a quiet moment, maybe at 2 a.m. when you can't sleep, you start to wonder if this is just what your life is now. If this is the new baseline. If the person you were before Sjögren's is simply gone, and this slower, foggier, more fragile version is who you are from here on out. I want to stop you there. Because that conclusion, that surrender, is not the truth. It is what happens when subclinical flare activity goes unrecognized and unnamed for long enough that the patient absorbs it as identity rather than pathology. You are not a diminished version of yourself. You are someone whose disease is still active, just quietly. And that is a medical reality, not a character flaw. Now let's get into why the tests miss it. Because this is the part that creates the most damage, not because anyone is doing anything wrong, but because of a fundamental mismatch between what standard testing measures and what subclinical Sjögren's actually does. When your rheumatologist assesses your disease activity, they are typically looking at a specific set of markers. ESR, erythrocyte sedimentation rate, which measures how quickly red blood cells settle in a tube, a proxy for systemic inflammation. CRP, C-reactive protein, a protein the liver produces in response to inflammation. Complement levels, C3 and C4, which can drop when the immune system is in overdrive. And antibody levels, SSA and SSB, which reflect the presence of the autoimmune response itself. These are legitimate, clinically useful tests. I am not dismissing them. But here is what they cannot do. They cannot measure neuroinflammation, inflammation occurring specifically within the nervous system, behind the blood-brain barrier, in a compartment that standard serum testing does not access. They cannot assess small fiber neuropathy, damage to the tiniest nerve fibers in your body, which produces symptoms like tingling, burning, and altered sensation without showing up on standard nerve conduction studies. They cannot tell you what is happening inside your salivary and lacrimal glands at the cellular level without a biopsy. They cannot capture autonomic nervous system dysfunction, disruption in the unconscious systems that regulate your heart rate, your digestion, your sleep, your temperature, which is increasingly recognized as a significant feature of Sjögren's. And critically, they are snapshots. A blood draw taken on a Tuesday morning tells you what was happening in your bloodstream on that Tuesday morning. It does not tell you what happened on the Thursday before when you crashed so hard you couldn't leave the couch. It does not tell you what was happening in your trigeminal nerve last night when your face went numb for an hour. So when your results come back clean and your doctor says you're stable, believe them about what the tests showed. But understand that the tests are looking through a narrow window at a much larger room. And what they're not seeing may still be very much there. Type still flaring in the comments if you have been handed a clean result while feeling anything but clean. You are not alone in that room. And you are not wrong about what you're feeling. Here is where things get important. And I need you to stay with me through this next section because it is the part that explains so much of the confusion that comes with Sjögren's. When a flare shifts from acute to subclinical, when it stops screaming and starts whispering, the place it whispers loudest is the nervous system. Not the joints. Not the glands. Not even the eyes, necessarily. The nervous system. And the reason for this is rooted in the biology of the disease itself. Sjögren's is not simply a glandular disease anymore, the research has made that clear. It is a systemic autoimmune disease with significant neurological involvement. The same immune mechanism that attacks the moisture-producing glands, lymphocytic infiltration, cytokine release, antibody-mediated damage, also targets peripheral nerves, autonomic nerve fibers, and in some cases, the central nervous system itself. And when that neurological activity is the primary active component of a quieter flare, the symptoms it produces are not the ones patients are told to watch for. They are subtler. They are easier to rationalize. They are the kind of thing you dismiss as stress, as bad sleep, as getting older, as anxiety, until you understand what's actually generating them. Let's go through them one by one. Not as a list. As a story. Because this is how they tend to show up in a real person's real life. It starts with the thinking. You used to be sharp. Maybe not in an exceptional way, just normally sharp. You followed conversations easily. You could hold multiple things in your mind at once. You remembered where you put things, what you were going to say, what you meant to do. That was just how your brain worked. It was not something you noticed because it required no effort. And now it requires effort. Now you read a paragraph and realize halfway through that you haven't absorbed a word. Now you're in a conversation and the word you want, a simple word, a word you have used 10,000 times, just isn't there. You reach for it and find a blank space where it should be. And you have to talk around it, or laugh it off, or just say never mind and move on. Now you make mistakes in sequences you've done 100 times. You forget a step in your own routine. You put things in wrong places. You lose chunks of time, not dramatically, not frighteningly, just in the ordinary way where in our past and you have nothing to show for it and you're not sure where it went. This is called cognitive dysfunction. In Sjögren's literature it is sometimes called Sjögren's fog, though that name undersells it. It is not a soft haziness. On bad days it is a genuine impairment. And it is driven by neuroinflammation, by the immune system's activity within and around the central nervous system, which means it does not require a dramatic spike in your standard inflammatory markers to be present and active. It can be happening right now, in the middle of a period where your labs look fine, while your doctor believes you are stable. And it tends to be worse during subclinical flare activity, even when everything else seems quieter. Because while the glandular symptoms may have pulled back, the neurological ones can persist, or even intensify, without the kind of systemic inflammation that standard panels would catch. If your thinking has been slower than usual. If words have been harder to find. If your ability to concentrate feels like it has a ceiling it didn't used to have. That is not you. That is the disease, still active, just in a different place. Then there's the body sensation piece. And this is the one that tends to frighten people the most, because it feels neurological in a way that the brain fog doesn't. It feels like something is physically wrong with the wiring. Tingling. That's usually where it starts. Not constant, intermittent. A buzzing in the tips of your fingers that comes and goes. A pins and needles feeling in your feet when you haven't been sitting still. A strange aliveness, almost electrical, in your face. Around your lips. Along your jaw. In your cheek, on one side or both, that seems to have no obvious cause. You've Googled it. Of course you have. And Google has given you a terrifying list of possibilities that you've had to talk yourself down from at various points. What Google has probably not told you is that peripheral neuropathy, nerve damage driven by immune activity, is present in somewhere between 10 and 60% of Sjögren's patients, depending on the study and the method of detection used. That is not a rare complication. That is a core feature of this disease that is dramatically underrecognized. And here is what makes it particularly relevant to the question of whether your flare is over. Peripheral neuropathy in Sjögren's does not require an acute flare to be active. It can persist, progress, and produce new symptoms during periods that look clinically quiet. The nerve damage that began during the acute phase does not automatically stop when the acute phase softens. And in some patients, the neurological involvement actually becomes more prominent as other symptoms quiet, not because something new has started, but because without the louder symptoms competing for attention, the nerve-related ones finally get noticed. So if you are in what you believed was a post-flare period and you are experiencing tingling, buzzing, numbness, or strange sensory phenomena, that is not a new problem appearing out of nowhere. That is almost certainly the same disease process, still running, now visible because the noise around it has quieted. This is worth telling your doctor about specifically. Not as a passing mention, but as a focused concern. The language to use is, I have been experiencing intermittent tingling and altered sensation, and I would like to explore whether this could represent peripheral neuropathy related to my Sjögren's. I would like a referral for nerve conduction studies and possibly quantitative sensory testing for small fiber involvement. Small fiber neuropathy, in particular, is a form of nerve damage that standard nerve conduction studies miss entirely, because it affects fibers too small to be measured by traditional EMG. A skin punch biopsy is required to detect it. Most patients are never told this. Most patients are sent for a nerve conduction study, told it came back normal, and sent home reassured, while small fiber damage continues. Sleep is the next piece. And it is deeply connected to the neurological picture, which is why I'm placing it here rather than treating it as a separate topic. Most Sjögren's patients will tell you they are tired. Chronically, persistently, profoundly tired in a way that does not match their activity level or their sleep quantity. They sleep. Sometimes they sleep a lot. And they wake up tired anyway. This is not weakness. This is not laziness. This is a recognized feature of autoimmune-related sleep disruption, and it operates through a mechanism that is almost never explained to patients. Sjögren's affects the autonomic nervous system. The autonomic nervous system is responsible for regulating the unconscious processes that keep you alive and functional: heart rate, blood pressure, digestion, temperature regulation, and critically, the architecture of your sleep. The stages of sleep, the transitions between light sleep, deep sleep, and REM, are orchestrated in part by autonomic signaling. When that signaling is disrupted by autoimmune activity, the architecture breaks down. You may spend the night technically asleep but cycling through shallow stages, never reaching the deep slow-wave sleep where physical restoration actually happens. Or you may reach deep sleep but be pulled out of it repeatedly by autonomic dysregulation, waking at 3 a.m. with your heart rate elevated and your mind already active, unable to understand why. And then there is the inflammatory component. Cytokines, the chemical messengers released during immune activation, directly affect the brain's sleep-wake regulation. Elevated cytokines, even at subclinical levels, promote a state of what researchers call sickness behavior, a coordinated neurological response that includes fatigue, social withdrawal, cognitive slowing, and disrupted sleep. This response exists for a reason. In acute infection, it conserves energy for immune function. But in chronic autoimmune disease, it can become a persistent state that has nothing to do with how much you slept last night. So when you wake up exhausted after 8 hours, or when you cannot stay asleep past 3 a.m., and your doctor suggests sleep hygiene or asks if you're stressed, understand that there is a biological mechanism operating beneath that. One that is connected to your disease activity, not to your habits or your mindset. If your sleep has been disrupted in the ways I've just described, the unrefreshing nights, the middle of the night waking, the crushing daytime fatigue regardless of hours logged, type still flaring in the comments. Because this is the symptom that gets dismissed most often. And it is one of the most reliable signals that the flare has not actually resolved. Now the mood piece. And I want to handle this carefully because it is the one most likely to have been used against you. If you have experienced anxiety, low mood, irritability, or emotional flatness during or after a Sjögren's flare, and if you have mentioned this to a doctor, there is a reasonable chance the response you received was primarily psychological in framing. That these feelings were attributed to the stress of being chronically ill. That therapy was suggested. That the possibility of a prescription for an antidepressant or anxiolytic was raised. Those are not inherently wrong responses. The psychological burden of chronic illness is real, and support for that burden is legitimate. But what is almost never discussed in those appointments is this. The mood changes and anxiety-like symptoms that Sjögren's patients experience are not purely psychological reactions to their circumstances. They are, in many cases, neurobiological, driven directly by the same immune mechanisms driving the rest of the disease. Here is the mechanism. Inflammatory cytokines, particularly interleukin-1 beta, interleukin-6, and tumor necrosis factor alpha, cross the blood-brain barrier and directly affect the limbic system, which governs emotional processing, fear response, and mood regulation. Elevated cytokines reduce serotonin availability, disrupt dopamine signaling, and activate the amygdala, the brain's threat detection center, in ways that produce anxiety, hypervigilance, and low mood without any psychological trigger. This means that when Sjögren's is active, even subclinically, it can produce a persistent low-grade anxious or depressive state that has a direct biological cause. It is not a response to your life circumstances. It is a symptom. And it tends to track with disease activity, meaning it gets better when inflammation is genuinely controlled, and it does not fully resolve through therapy alone if the underlying immune activity is still running. This does not mean therapy is useless. It can absolutely help with the psychological layer that exists alongside the neurobiological one. But it does mean that if you have been feeling anxious, flat, or emotionally not quite yourself since your flare supposedly ended, that experience is connected to what is happening in your body. It is not a separate problem. It is the same problem, expressing itself differently. Let's bring this together now. Because everything I've described, the cognitive fog, the tingling, the unrefreshing sleep, the mood disruption, these are not isolated symptoms. They are cluster. And clusters have patterns. The pattern they describe is a nervous system under ongoing immune stress. Not the dramatic, obvious, acutely ill kind of stress. The quiet, chronic, grinding kind that doesn't make headlines in your blood work but writes itself into every hour of your day. And here is what that pattern tells us about your flare. If you are experiencing two or more of these things, the brain fog, the sensory symptoms, the sleep disruption, the mood changes, in a period that you believed was recovery or remission, the probability that your flare has genuinely resolved is low. What is more likely is that the flare has shifted. It has moved from the acute glandular phase, the one that shows up on labs and produces the symptoms you were told to watch for, into a neurological phase that is harder to detect, harder to name, and far too easy to absorb into daily life as the new normal. The distinction matters enormously. Because a flare that has shifted is not being managed. And an unmanaged, persistent immune process continues to do what immune processes do: damage tissue. Slowly. Cumulatively. in ways that only become fully visible later, when reversing the damage becomes much harder than it would have been to prevent it. This is why naming it matters. This is why recognizing the pattern matters. Not to frighten you, but to give you back the power to act on what your body has been telling you all along. I want to say something directly now. And I want you to actually hear it. If you have been told you're fine, if the test came back normal, if the appointment ended with reassurance, if the people around you believe you're better because you're upright and functioning, and you do not feel fine, your experience is not wrong. Not wrong as a perception. Not wrong as a medical signal. Not wrong as a basis for continued investigation and continued advocacy for yourself. The gap between what the tests show and what you feel is not evidence that the tests are correct and your body is confused. It is evidence that the tests are measuring something real but incomplete, and that what falls outside their measurement range is also real. You have been navigating a disease that is genuinely complex. One that the medical community is still developing better tools to understand and measure. One where the patient's subjective experience frequently outpaces the available diagnostic infrastructure. That is not your failure. That is the current state of the science. But it means you cannot afford to outsource your understanding of this disease entirely to lab results. You have to know what you're looking for. You have to be able to recognize the signs that the flare is still active, even when nothing on paper confirms it. Because you are the one living in this body. And nobody has more data about this body than you do. So what are the signs? The specific ones. The ones that tell you the flare has not truly ended, that it has just changed address. Some of them we've already covered. The cognitive fog that persists or worsens past what you'd expect in recovery. The sensory symptoms that come and go without explanation. The sleep that doesn't restore. The mood that sits lower than it should. But there are others. The kind of fatigue that is not proportional to what you've done, where a normal Tuesday wipes you out the way a marathon used to. The post-exertional malaise where doing something ordinary leaves you worse for the next 2 days in ways that feel almost punitive. The temperature dysregulation, being cold when others are warm, or suddenly flushing when nothing has changed, which reflects autonomic nervous system involvement. The heart rate irregularities, a pulse that climbs too fast when you stand up, that takes too long to settle after minimal exertion, which is a recognized autonomic feature of Sjögren's called postural orthostatic tachycardia, or POTS, in some patients. The headaches that are different from the ones you had before, pressure-like, or located at the base of your skull, or accompanied by light sensitivity that feels disproportionate to the headache itself. The digestive disruption, motility issues, bloating, nausea without obvious cause, driven by autonomic dysfunction affecting the gut's own nervous system. The episodes of intense, bone-deep exhaustion that seem to come from nowhere and then lift as inexplicably as they arrived. None of these are dramatic. None of them will bring you to an emergency room. All of them will be rationalized, by you, by the people around you, possibly by your doctor, as stress, or aging, or the aftermath of a difficult period. But in the context of Sjögren's, in the context of a flare that appeared to end but left you with these ongoing signals, they are a map. They are the disease showing you where it went. I put together a symptom map specifically to make that map visible. It takes the patterns we've just discussed, the neurological signs, the autonomic features, the cognitive and sensory symptoms, and places them in a progression framework that shows where they fit in the disease process. It shows what typically comes first, what follows, what the difference looks like between a flare that is resolving and one that has simply shifted. And it comes with a full research PDF that goes deeper than anything we could cover in a single video, test by test, symptom by symptom, with the language you need to bring this to a medical appointment and be taken seriously. Type symptom map in the comments and I'll send it to you directly. Or find it linked in the description. It is not a free download, the research behind it required real work, but the price is as close to nothing as I could make it while still honoring what went into it. Because the people who need it most are the ones who have already spent too much money chasing a diagnosis that keeps slipping through the cracks of standard testing. Here is what I want you to leave this video understanding. A flare that goes quiet is not the same as a flare that ends. The silence is not remission. It is a change in frequency, from a register your tests can hear, to one they cannot. But you can hear it. You have been hearing it. That's why you're still here, 20 minutes into a video about something your doctor told you was resolved. The nervous system does not lie. The fatigue does not lie. The brain that won't quite cooperate, the sleep that won't quite restore, the mood that sits at an angle to everything, none of it is lying. It is all signal. And signal, properly read, becomes information. And information becomes action. The action here is to stop accepting "you're fine" as a complete answer when your body is providing evidence to the contrary. To learn the specific signs that indicate ongoing subclinical activity. To bring those signs to your medical team with specificity and language that demands engagement. To understand that you are entitled to a full picture, not just the portion that fits within the range of a standard blood panel. You are not at the end of this. You are in the middle of it. And the middle, as disorienting and exhausting as it is actually the place where things can still change. Where intervention still makes a difference. Where catching what's still running can prevent what comes next. That is not a small thing. That is everything. Type symptom map below. Or type still flaring if this video just put a name on something you've been carrying for months without knowing what to call it. Either way, don't sit with this alone. The pattern is recognizable. The signs are there. And now, so are you.